I thought that what I would do is talk a little bit about a framework for thinking about can antiretrovirals in particular change the epidemic nationally and also here in San Francisco. So you're going to see some things that you saw last week in Vivek's presentation, as well as some of the things that you saw in Getting to Zero. I'm just putting them together in a slightly different way. These are my disclosures. I do participate in studies for which Gilead's provides study drug, and I also just need to say that when I make recommendations, they're not official health department recommendations. So when I think about what we need to actually drive down HIV infections, I think about how do we move from clinical trials to population level effects. And so I think of four components that need to be considered. You need to be targeting this at the right population, so that's HIV epidemiology. You need to have effective interventions, not just how they've worked in efficacy trials, but how they work in real life settings. You need to be able to scale them up, because you could have a fantastic intervention, but if it can't be scaled, then it's not going to make a difference. And then it needs to be desirable to the population that's going to be using it. And that has to do with adherence and persistence. And then I have an extra little bonus component that's about new agents and new formulations, but I'm not sure I'll get to it. So if I don't get to it today, we'll do it on another day. But so it's epidemiology, effectiveness, coverage, adherence and persistence, and then new agents. And the way that I tried to remember that outline was just he can, but some of us believe she can. So let's start with populations at risk in the United States. I think most of you know that men who have sex with men account for the largest number of diagnoses, not just percentage of diagnoses, and also the only population in whom new diagnoses are increasing nationally. And if we look specifically then in men who have sex with men by age, you can see that the 13 to 34-year age group are the ones in whom new infections are both highest and increasing. And if you take the youngest age group, the 13 to 24-year-olds, you can see these massive disparities, racial and ethnic disparities. Again, this is number of diagnoses. So this is completely out of proportion to the size of the population for both African American and Latino men who have sex with men. So what's the story in San Francisco? And I believe you saw some of these data at the Getting to Zero presentation, but this is the population in men and women. And I've shown you the population rate per 100,000. So this is not for just MSM, this is all men and all women, because we need to adjust for the fact that we have a really small population of African Americans, and yet look at the rates in 2015 of new diagnoses. Even though the trend is going down, in the last year it didn't look like it was going down, but it's substantially higher than in, and it's also substantially higher in Latino populations than in white populations and Asian Pacific Islanders. And you see this really dramatic disparity in African American women. And I think one of the things that sort of took my breath away in looking at this was that if you look at the rate in women, it's almost the same, in African American women, it's almost the same rate as in white men. So we think of our epidemic as being largely MSM in San Francisco, because it is, but we still have a very substantial epidemic in African American women. So here's your first audience response. And this is the only sort of true fault, like there's a right answer. The other ones, there's no right answer. But who had a greater number of new diagnoses, the young or, you know, when we talk about old as being over 50, I like to say older. So is it the 13 to 24-year-olds? Is it the over 50-year-olds? Is it about the same in the two groups, or do you not know? So take just a moment if you are going to do the audience response to respond. And I hope you'll get onto the audience response for the other ones, because it's really about practice decisions, and it would be really helpful to hear what people are doing. Okay, so do I advance this to get to the number? So most people think it's 13 to 24-year-olds, which is generally about what most people think. And yet, if you look at it, you know, there's a big chunk in the 25 to 29-year-olds, but in the 13 to 24-year-olds, it's almost the same number as in the over 50s. And so while some of these are clearly probably late diagnoses, a lot of these are new infections. People who are 50 and over are still at risk for HIV infection, so it's really important to ask all of your patients about risk practices and to think about PrEP. And in fact, if you look at the San Francisco data, you can see again that the 18 to 24-year-olds and the 50-plus-year-olds are about the same number. So one of the questions is, so where are these new infections coming from? And the good news is that very few of them are coming from people who are on antiretroviral therapy or actually retained in care. So this is retained in care not on therapy. This is retained in care on treatment but not fully virally suppressed, and this is virally suppressed. Over 90%, this is modeled by Jacek Skarbinski, who many of you may know, who trained here. About a third of them are from undiagnosed, but about 2/3 are from people who are diagnosed but not retained in care. And so this is really important both for their health and for the health of the community in terms of transmission risk. I also just wanted to make one point about the heterosexual epidemic, which is that it's very closely tied to income. And when you look at the lowest income level and the prevalence of HIV in the heterosexual population, it looks pretty much like Haiti's generalized epidemic. So we have this intersection of poverty and HIV, as well as of race and HIV. And so if you look at the overall population, you can see that there's this substantially higher prevalence in Black and Latino than white populations. And yet among the poverty areas, because we've got, unfortunately, these structural barriers and structural inequities that lead to larger populations of Black and Latino populations living in poverty, you don't see the same disparities between the two of them, and the disparities are lesser than in the white population. So I should also say I'm going to summarize at the end of each of these sections because I'm going to be flying through a bunch of data. So this is my summary of the epidemiology component. It's that men who have sex with men are the population at largest risk, both in San Francisco but also across the country. We can't forget, though, that substance use does drive the epidemic. So even though we've seen a decline in new infections in people who inject drugs, in San Francisco, I think that's largely because we've got great syringe access programs and harm reduction programs. But both injection drug and non-injection drug use does in part drive the epidemic, particularly in men who have sex with men. We need to take into account these racial and ethnic disparities and address those, and that's the disparities are increasing nationally. We need to pay attention to all age groups. So that's, youth have particular vulnerabilities. We definitely need programs for youth, but we've also got these older populations that we also need to deal with. The HIV epidemic in heterosexuals is an intersection of both race, ethnicity, and poverty. And we have issues about keeping people living with HIV in care, and that's critical both for their health as well as for transmission risk. So now we're moving to the E, effectiveness. So how do data from clinical trials translate into real-world effectiveness? And so I think most of you know about the HPTN 052 study. It was a study of over 1,700 mostly heterosexual, 97% heterosexual, serodiscordant couples in which one partner's positive, the other's negative. And they were randomized. They all came in at CD4 counts of 350 to 500. At that point in time when the study was being done, the recommendations in the countries in which it was being done were only treatment below generally 200 or 250. And so they were randomly assigned to either get to an immediate treatment arm, which was they started antiretrovirals at 350 to 550, or delayed. They started only when they met their national guidelines. In that, and what they were looking at, in addition to how well the positive partners did in terms of their health, they wanted to see about transmission to the uninfected partner. There were 39 transmissions. 28 of those were linked, which meant that when you looked at the phylogenetics with high probability, it was that positive partner who transmitted to that negative partner. Only one of those was in the immediate arm. 27 of them were in the delayed arm. There was 96% protection in that study. I do want to point out that 11 of them were unlinked, meaning that the HIV uninfected partner got infected from outside of the partnership, and I'll come back to that because that's a recurrent theme. So there were updated data published this year in the New England Journal of Medicine from HPTN 052, in which now 36% of the transmissions were unlinked. So I will just say that in almost every study I've seen, it's a quarter to a third of transmissions are occurring outside of partnerships. There were 8 linked transmissions in couples in whom the positive partner was on treatment, but for 4 of them, it was in the first 90 days of treatment, so it may have been before they were fully virally suppressed. And in 4, it occurred after failure of viral suppression in the positive partner. The other question is, and this is where I get sometimes concerned from a public health standpoint, is just we do have the message that if you're fully virally suppressed, you are very unlikely to transmit. The question is, are you fully virally suppressed? And so this was data presented or published last year, looking at a cohort of people in 6 US clinics who were being followed a median of more than 3 years. And they just looked to see how often is their viral load over 1,500, because that was the threshold at which transmission occurred if they were in the Quinn paper in the very early days when they were looking at the role of viral load, plasma viral load, and transmission. Below 1,500 transmissions were not occurring, and over 1,500 they were occurring. And you can see that most people, when they're in care, are being prescribed antiretroviral treatment, 90%. But more than half had a viral load of greater than 1,500 at least part of the time. And 23%, a quarter of the observation time, included people over the level of 1,500. So I think when we think about stable serodiscordant partnerships where the negative partner really knows what's going on in the positive partner's health, that's great. If you're hooking up and somebody just says, oh yeah, I'm fully virally suppressed, they may or may not be. And so I think we need to counsel our patients about what does it mean to be fully virally suppressed and to be at very low level or no level of potential for transmission. So let's look at these serodiscordant couples though. This is the ideal situation because you've got these stable partnerships. Does transmission occur? So there's the partner study that was presented over the summer in which 888 serodifferent couples, most of them were heterosexual, some were MSM from 14 European countries. The positive partner had to be on antiretroviral therapy, viral load of less than 200, and they had to have said that they were planning to engage in condomless anal sex, or condomless vaginal or anal sex in the future. The men had been in stable partnerships for an average of 5 years before the study, and the heterosexuals an average of 11 years. So remember, whatever was keeping them serodiscordant, whatever was keeping the negative, had been going on for some time. And they were followed for a median of 1.3 years. Now the good news is that there were no new infections between the partners, but given the frequency of receptive anal sex, which was somewhat lower, there were fewer MSM and it wasn't very common in heterosexuals, the upper bound of the 95% confidence interval for the risk in that for receptive anal sex was as high as 2.7%. So the good news is there were no infections. So it looks really great, but I don't think we can say with certainty it never occurs. And there were 22 negatives, yet again, who were infected from outside the partnership. So you can't assume because someone's in a serodiscordant relationship that they don't have other partners. There was also data presented on opposites attract, and what was exciting about this study is it's a study specifically focused on men who have sex with men, 359 serodiscordant couples, MSM couples, and again, great news, no transmissions. They said their caveat was 90% were either the positive was on treatment or the negative was actually using condoms. So I think what we can say is the risk is very low. I don't think we can yet say that it's zero. So let's take a look at what we know about efficacy of pre-exposure prophylaxis. And these are the range of pre-exposure prophylaxis studies. This comes from the AVAC website, which I highly recommend. It's got a lot of great infographics and information about prevention trials. This line I drew is the difference between those that are effective, which are to the right of the 0 line of effectiveness, and those that are would be an increased risk if they didn't cross the line. So none of them showed people were at increased risk, but a number of them showed no significant protection. So the range of protection, though, varied from 27% from the recent vaginal ring study, ASPIRE, to 86% for 2 MSM studies. And one of the questions is, why do we see those disparities, and why in particular do we see these studies in the bottom, which are predominantly in women, where we're seeing no efficacy or effectiveness? Because these were efficacy studies, except for the PROUD study, but because a lot of the participants were not using the drugs, they can be considered an effectiveness estimate. And as I said, we've got very high levels of protection in men who have sex with men and in serodiscordant heterosexual partners in Eastern Africa who were on TDF-FTC as their PrEP. There was a group that was also on just TDF alone, and they had an efficacy of 67%, which was lower, somewhat lower. So this is also from the AVAC website, that there's this direct relationship between the effectiveness and the proportion of patients who are taking the drug. So if you're not taking it, obviously it can't work, right? And so what I did was I also attached to each of these dots, these are all the different studies, I attached which population. And what you can see is that for MSM, they are pretty high, except for IPREX, where only about half of them were taking the drug. And heterosexual couples and men and women were pretty much bunched at the top, but there's this question about what's going on at the bottom here. Is it just that effectiveness is low because women have not wanted to take PrEP for any of a number of reasons, or are there other potential explanations? And I believe that Vivek talked some about this last week. There was an interesting presentation, special session actually, at the International AIDS Conference that was really focused on, does the vaginal microbiome affect susceptibility to HIV infection, but also does it affect the effectiveness of tenofovir? And this was in a gel-based study, so this is the CAPRISA 004 study. And what they found was that in a healthy vaginal microbiome, it's lactobacillus predominant with a low pH and an intact mucosa. When there's dysbiosis, there are all of these other pathogens that are present. The pH is higher, and there's disruption of the mucosal membrane. And what they found was that that it was only in the healthy vaginal, the women who had a lactobacillus dominant microbiome, where PrEP was effective. And these are the data, which is a post hoc analysis, so this is hypothesis generating, it's not confirmatory. But what they did is they separated the women into those who had a lactobacillus dominant vaginal microbiome, those in whom it was a non-lactobacillus dominant microbiome. The efficacy in the lactobacillus dominant biome was 61%, whereas it was only 18% and not statistically significant in the non-lactobacillus dominant. And they went on to sort of look at what the story was of the tenofovir levels in the supernatant, and were surprised that that in the Gardnerella predominant, it was the tenofovir was being taken up in the cells, whereas that was not the case for the ones with the non-lactobacillus dominance. So again, this is all just hypothesis generating. What's happening to metabolism, what's happening to uptake of drug in a healthy vaginal microbiome versus one that's less healthy. I did want to take a moment to talk about effectiveness in people who inject drugs. There's only been one trial so far of efficacy in people who inject drugs, and it was using tenofovir alone, not TDF-FTC. And this was a trial in which many people opted for the directly observed therapy component, so they actually had higher adherence than you would necessarily expect. And when they looked at the adherence compared to the effectiveness, you can see that you needed 97.5% adherence under directly observed therapy to get to the 80% or higher effectiveness level. And so there are a couple of questions about this. It may be that you don't have the same forgiveness with tenofovir-based regimens if you're being exposed parenterally versus rectally versus vaginally, which I'll talk about in a moment. Or it may be that it was tenofovir alone and not TDF-FTC. So it's just something to think about. It definitely, PrEP works for people who inject drugs, but they probably need to take it very consistently and every day. These are data, effectiveness data from San Francisco largely. So this is Kaiser data from Jonathan Volk, who also trained here, and they had over 650 men on PrEP at Kaiser. Very high rates of STDs, no HIV infections, which is great. PrEP Demo Project, a study that was done here in San Francisco, in Washington, D.C., and Miami. 557 men who have sex with men and transgender women. Again, high rates of STIs. 2 breakthrough infections occurred in that case. Both of them had completed their PrEP regimens some period of time before they were detected to be positive. So it's assumed that they were infected actually at a time when they were no longer actively on PrEP. But PrEP is not perfect. So we have 2 cases of men who were being treated for hepatitis B infection who became infected sexually, and 1 man who was on TDF-FTC who was infected with a multi-class resistant HIV. And so, again, it's very highly effective if taken regularly. And for men who have sex with men or for rectal exposure, it's probably that you've got some forgiveness because the levels are about 100-fold higher in rectal tissue than in vaginal tissue. So you can probably get away with 4 days a week to 7 days a week based on a number of modeling studies. With women, you probably need to take it 6 to 7 times a week in order to really achieve high levels of effectiveness. So how do you put PrEP and antiretroviral treatment together? And what the Partners PrEP study did in East Africa was they said, what we're going to do is run a demonstration project. All of the positive folks are offered antiretroviral treatment immediately. The negative folks are offered PrEP immediately. And they get to stay on PrEP for 6 months overlap while the positive partner is being fully virally suppressed, because they had data from their earlier studies that suggested in the first 6 months of antiretroviral treatment, they did not see a reduction in transmission events. So if the positive partner started right away, the negative partner was on for the first 6 months and then stopped PrEP. If the positive partner delayed starting on antiretroviral therapy, they still allowed this 6-month overlap period. And they wanted to know how effective was it. Well, what they found was a 95% reduction in new infections based on what they would have anticipated it to be based on the earlier studies. And again, the cases with the infections, there were issues about the adherence on the positive partner's part or the breakup of relationships. So it does look like PrEP can serve as a bridge for antiretroviral treatment as long as the positive partner is being stably virally suppressed. So here's my question to you. How do you advise serodifferent couples about condom use? And I want to know specifically for HIV. Do you tell them there's no need for condoms if the positive partner is fully virally suppressed? Do you say there's no need for condoms if the negative partner is on PrEP? Do you say they actually need both viral suppression and PrEP before stopping condoms? Or do you say, you know what, actually, you don't need all this antiretroviral treatment because condoms are more effective than antiretroviral therapy or PrEP? So I'm interested in hearing what you all think. Okay, so there are no right answers, but I do want to point out one place where there is a lack of knowledge about condom effectiveness. So most people are saying both, which I think is a reasonable thing, particularly at the beginning, or particularly if a positive partner is not fully virally suppressed. But condoms are not as effective as I think people think they are. I think they sort of say, oh, well, but condoms completely protect. Well, in effectiveness studies for heterosexual sex, in a study of over 10,000 couples, 71 to 77%. And in a study by Don Smith at CDC, 70% effective for men who have sex with men. Now that's effectiveness, and that's probably takes into account the fact that people are sometimes saying they're using condoms when they're not. They may be not aware if a condom is not being used the entire time. They may not recognize that it needs to be used the entire time. And condoms break and slip off. And so condoms are really important for sexually transmitted infection control. There's no question. And they do provide a level of protection for HIV. But let's see my summary of the effectiveness piece is that antiretrovirals as treatment or as prevention are highly effective with some caveats. The protection may fail for antiretroviral treatment if there are outside partnerships, if it's early after antiretroviral treatment initiation, or if there's failure of viral suppression. But in both cases, for both the positives and the negatives, you need to take the pills for them to work. So for treatment, you need to be sure the partner has an accurate assessment of their stability of viral suppression. And for PrEP, there are clinical data and modeling studies that suggest that women need to take daily TDF-FTC with high adherence to achieve maximal protection, and that nothing's actually 100% protective. And we had a participant who came in who said his doctor told him it was 100% effective, and he was infected, but we unfortunately were not able to get him to come back in. We learned about this after the fact. So, and condoms are effective, but my, again, personal belief is that they should never be used as an excuse not to give PrEP. So we're at the C, coverage of antiretroviral treatment and PrEP. And here again, if you've got an incredible intervention, but you can't get it out to many people, then it's not going to be highly effective. And how are we doing with antiretroviral treatment? Well, these are data from 2012, but you can see that in terms of viral suppression, the estimate nationally is 30%. And that once people are maintained in care, very many of them are prescribed antiretroviral treatment, and most of them are virally suppressed. It's just getting and keeping people in care. So how are we doing in San Francisco? Well, we're doing more than twice as well. The green lines are San Francisco, the blue lines are California as a whole. The estimate here is that 67% of San Francisco cases are virally suppressed. But it means a third may not be. Now, some of them are people that, these are people who we don't know to have died or moved away, but some of them we don't really know if they're in care somewhere else or not. PrEP uptake, the coverage has really taken off in the last couple of years. From 2012 all the way to 2015, there's over a 700% increase in uptake. But, and they're estimating around 80,000 unique individuals. This is coming from a pharmacy database that Gilead presented at the international conference. I think one of the questions is who's getting PrEP? And initially it looked like a lot of women were getting PrEP and not as many men were getting PrEP. Now it looks like it's about a 4-to-1 ratio of men to women. So we're getting more men on PrEP. The problem is we're reaching some younger women, but we're not reaching as many young men as we need. And when you look at race ethnicity, this is the, on the left is PrEP utilization, and on the right is the racial and ethnic breakdown of new infections. And you can see that African Americans make up 44% of new infections, but only 10% of PrEP uptake. Latinos, 23%, and only 12% of PrEP uptake. So again, we've got these disparities and inequities that are driving these disparities in the epidemic. I do want to give this caveat. So they showed this slide and said, These are the numbers per city. And at the time that they were estimating that there were 1,000 people in San Francisco, we were estimating more than 6,000. So we know that their estimate is an underestimate of PrEP uptake. And so all of these numbers need to be taken with a grain of salt. If we look at what we think is going on in San Francisco, from City Clinic, we have suggestion that from 2012 to 2015, now almost 30% of those who are eligible for PrEP are actually on PrEP. That's good. We're moving in the right direction. And we've actually almost tripled the number of people that we're estimating are on PrEP. There's some issues about measuring this in an accurate way. So we're estimating that right now approximately a third of the people, of the men who have sex with men who could benefit from PrEP are on PrEP in San Francisco. So again, that's good, but we've still got quite a long way to go. And these are about the disparities in men who have sex with men in San Francisco. So 2014 and 2016, we're improving everybody's going up. We're improving some of the disparities. Our lowest rates are in Latino men who have sex with men, so that's something that's really important to take into account. And we're also still not reaching the number of African Americans that we need to reach given the high infection rates. So what we'd like to do is be able to create a PrEP cascade, and we really don't know, until we know the PrEP cascade and know about who wants PrEP, who's offered PrEP, who's able to successfully navigate to PrEP, we don't really know where our holes are. And so fortunately, Al Liu and Aaron Wilson and a group of others have come together and gotten a grant to try to measure this PrEP cascade in San Francisco, which I think will be very important for us. So the summary of coverage is that for antiretroviral treatment, if you're in care, you're very likely to be offered an on ARTs, but we need to focus on that earlier stage of the cascade and retention in particular. PrEP is taking off, but we still have a way to go. Data are lacking on the PrEP cascade, and plans are underway to gather those data. And we need more concerted effort for coverage of subgroups, and that's particularly true for people of color and youth. Adherence and persistence. So this is a slide I like from Terry Blaschke, and it's showing a year's worth of follow-up and how many people just stop taking their meds based on the particular disease. And what you can see is that, depression is the worst, hypertension, we all know that people stop taking their meds, and that's particularly true for prevention. It's also true for treatment. So HIV was here. This is a somewhat older slide, but you can see that there's a pretty big drop-off, so that's something we need to work on. Then the question is about PrEP. Do people stay on PrEP? Well, this was data from the San Francisco site of the PrEP demo project, and they followed people for a year. And this was done at the STD clinic at City Clinic with minimal research procedures. At 4 weeks, 93% of those tested had protected drug levels, 4 to 7 doses a week. At 48 weeks, 87% of those tested had protected drug levels. That's almost 90% at a year. That's fantastic. But you have to take into account this blue part of the bar here, which is no visit, because some people just didn't come back. So this is among the people who were tested. So if you take into account the number who came back, it's 72%. So it's still better than what we're seeing in other settings, but it's not the 90%. And we were much better than the Miami or DC sites. Hyman Scott and Miranda, the head navigator here, have been doing chart reviews and looking at lab and pharmacy databases to see what's the level of PrEP persistence in the community-oriented primary care clinics that include Ward 86, GMC, Family Health Center, as well as like Castro Mission and Tom Waddell. And what they found is that the overall persistence over the past year was 67%. Now this is sort of a crude measure, and we're still trying to find the best ways of measuring this. There was no difference by gender or age, but there were some pretty big differences by clinic. I'll keep those confidential at the moment because we're still trying to sort things through. But there are different procedures at the different clinics too. In some clinics you can get an appointment when you leave, and some you have to call back for an appointment. In some clinics you have a navigator who's based there, and in some there's no navigator. For some you've got panel management, and in others you don't. So what we're trying to do is tease out what are the factors that are leading to high rates of persistence or low rates of persistence. And then by race ethnicity, you can see that, again, African Americans have the lowest rates of persistence and the lowest duration of PrEP. And Latinos are just behind that. So fortunately, we've gotten another NIH grant to look specifically at this issue of PrEP retention within the COPC clinics, and this is done in conjunction with the PRIDE study, which is a health department study that's focused on scale up of PrEP and scale up of treatment. There was an interesting study that was also presented at the International AIDS Conference in Black men who have sex with men, again, where we have some of these disparities. This was done in DC, Los Angeles, Chapel Hill. All African American men, 40% were under 25 years of age. They were offered TDF-FTC as PrEP. They didn't have to take it, but they were also offered a package of client-centered care that included individualized counseling, support, navigation services, and the tenofovir levels consistent with a protective level were 67% at 2 months and 56% at 12 months. So lower than that 72 or 73% in San Francisco, but better than what we've seen before. So it may be that packaging this with additional services is going to be quite important. We know that it's quite important for these men to be on PrEP because even among the people who had ever been on PrEP, the incidence was 2.9% per year. And among the men who didn't take PrEP, it was 7.7% per year. And that's just astronomically high. There was another study, ATN 113, that was done through the Adolescent Trials Network in 15 to 17-year-old young men who have sex with men. They screened over 2,800 men to enroll 79, so it was only 28% who took up the PrEP, who either were qualified or decided to take it. They also followed people for a year, 3 seroconversions, 6.4% per year, very, very high infection rates, and a predominantly African American and Latino population. And all three of those had low levels of, or no levels of tenofovir at the time of diagnosis. This is below the level of quantitation, less than 2 doses a day, 2 to 3 doses a day, over 700, so over 700 picograms per mil, which is consistent with 4 or more days in these dry blood spot samples. And what you can see is that for the first 3 months, it's about half to 60%, right, who had high levels of adherence. So that's actually not bad, particularly for this really young population. As soon as they went to quarterly visits, though, there was this tremendous drop-off, both in the people who were taking it at all, as well as in the people who were taking it, the high levels. And so it may mean that youth need closer follow-up. We're doing a study right now with colleagues in Chicago in which we've got an SMS texting system, and even though they know that the messages are automated, they say, it feels like somebody cares about me, and it makes me more likely to take these. So one of the questions that arises is, gee, is part of the issue that people aren't having sex all the time, so they don't really want to take drugs all the time. So I want to give credit to Jeff McConnell for coming up with this nomenclature, and Al Liu for creating this beautiful slide. But we have to talk about, when we talk about intermittent PrEP, we should be sure we're talking about the same thing. So if these little hearts mean sex, then fixed time-based dosing is just you take it regardless of when you're having sex. Event-based dosing means that you're taking it just before and just after sex. So it's not regular, it's sex dependent. Time-based plus event-based dosing means you're taking it regularly but perhaps less frequently, and you're boosting that with a post-sex dose. And periodic dosing means that maybe you have spells in which you're at higher risk. You're on vacation, you've just broken up, and you're taking PrEP during those seasons of risk. So we'll talk about those separately, but this is my last audience response question. Have you prescribed PrEP, and if so, how do you prescribe it? So answer the one that is that makes sense, that's furthest down, or that's highest up. You haven't prescribed PrEP, or you prescribe event-based dosing for some patients, maybe not for all, or you prescribe daily PrEP, but you give different adherence counseling to men and women, or you prescribe daily PrEP for men and women. I'd be interested in hearing what people do. Okay, let's just take a look. So most people, half the people are prescribing daily PrEP. Some are giving the additional information about differences in adherence, and not very many people are doing the event-based dosing, and about a third haven't yet prescribed PrEP, and hopefully there'll be ways that we can help you to start prescribing PrEP if you have patients who might qualify. These are data from the MAX study over an 8-year period, followed every 6 months. The red bars are when they had a risk score that they considered to be high. So there was a high-risk group. It was a minority who probably need PrEP pretty consistently. But there was a moderate risk group and even a low-risk group where there might be periods where intermittent PrEP would be applicable. So what do we know about this event-based dosing? Well, IPERGAY was presented again at the International AIDS Conference. They call it sex-driven iPrEP. They have a happy face that is demonstrating when sex occurs. You're supposed to take 2 pills 2 to 24 hours before, 1 pill a day later, and 1 pill a day after that. So 4 pills to cover each, to cover an episode of sex. And if you continue to have sex, then you continue to take 1 pill until you've completed 2 pills post-dose. And here are the infection rates. This was a 97% relative reduction versus placebo from their earlier studies. So very highly effective. But on average, they took 18 pills a month, which averages out to a little more than 4 a week, which may be the same as daily PrEP. So I don't think we yet have the data to know if intermittent PrEP works. It may, but I just don't think we know yet. These were data that they also presented, and this is from a paper that was published this year, in which they gave 49 women a double dose of TDF-FTC. And then these curves are the same up above and below, but the line is different. So the line shows when sex happened, or when sex would conceivably happen, 24 hours before or just 2 hours before. And they were looking at what level are protected, and what they pointed out was having a protective level of TDF or FTC. The solid line is just the TDF alone. And what they said is if you look at the combination, if you took it 24 hours before, then 98% reached this high level of protection, 81% if you took it just 2 hours before. So that tells us, they said it was 100% 4 hours later, but 2 hours is probably not enough, and a day is better to get up to levels. But if you want to look at what level is over 90% for tenofovir alone, then you need 3 days to achieve it, okay? And you need 5 half-lives, so you probably need at least 5 doses to get to steady state. This was data from, I guess it's from the same paper, looking at the EC90, the effective concentration that protected 90% in rectal tissue, and they were looking at what proportion of the patients achieved that by taking it 1, 2, 3, 4, 5, 6, or 7 days a week. And what you can see is that the men probably can get away with fewer doses per week, right? But the women, take a look at the TDF levels. You can understand now why it's anticipated that women need to take it probably at least 6 to 7 days a week. These are data from a group out of University of Colorado with whom we work closely. And what they were looking at is when are MSM specifically protected, and they were doing directly observed therapy. And what they found was that 89% achieved high levels after 7 doses and 98% by 13 doses. So their recommendation is that you start TDF-FTC 7 days before, if possible, but I think we all take a harm reduction approach to this, and if you don't have 7 days, start taking it as soon as you can. And they also recommend 28 days after, and I don't think we yet know if that's what's needed, but that's based on animal data. And the recommendation for women is that CDC is recommending is 21 days before and 6 to 7 doses per week. So if you're going to do intermittent PrEP, sex-dependent PrEP, you need to be planning for sex, right? So these are data from Jonathan Volk, a study that he did in over 1,000 men who have sex with men. About half of them said, yeah, their last anal sex was planned, but when you asked how long in advance was it planned, it might have just been minutes, which is kind of a planning, but it might not be enough to get you to protection. There's also a study in over 3,000 men who have sex with men, and half said that they had unplanned condomless anal sex in the past 3 months. There's a study that I call Hope Springs Eternal, which is just that they took 92 men who were HIV negative and said, are you going to have sex tomorrow? And each day they had to report, are you going to have sex tomorrow? Are you going to have sex tomorrow? And what they found was that men, if they said they weren't going to have sex, they definitely weren't going to have sex. But a lot of times they said they were and they didn't. So their recommendation was skip your daily dose only if there's a 0% chance that you'll have sex tomorrow, because it's hard to predict sometimes. And then there's this issue about vacation sex, and I think this is actually really important. 26% of men in this online survey said that they had condomless anal sex with new partners while on vacation. I think it's really important that we ask our patients who are negative, do your sexual practices change on vacation? If so, let me know, because we can start you on PrEP during that period of time. Because I've had patients say to me, you know, I don't get up much. I work really hard during the week, but when I go on vacation, I really go on vacation. So I think that really going on vacation, we should think about that as malaria prophylaxis. So my summary of this is that there's a substantial drop-off in med use for most meds, especially prevention, that there's high persistence in subgroups, but much lower in others. And not everybody needs to stay on PrEP. But what we've also found is that a number of people who have seroconverted recently who previously were on PrEP stopped PrEP because they didn't think they were at risk anymore. So they do need some reality check about what level of risk might they still have. Periodic PrEP is certainly useful for some people, and pericoital dosing has a lot of challenges with planning, with adherence, with pharmacodynamics. So again, my opinions here. And so if you try to put all this together and you look at what should we focus on then? Should we be focusing on coverage or adherence for PrEP? These are data from a modeling study that mapped coverage against adherence and then looked at what's the proportion of infections averted. Being in the darker, in the warmer colors up here and with the higher numbers shows like 55% averted, 50% averted. And what they found was that with low coverage, like 20%, no matter how high your adherence, you can't get higher than 20% reduction, right? But if you have high coverage, you can get a major impact even with relatively low adherence, and part of that is probably about the forgiveness. So it's really important that we get PrEP out to people and not worry so much that everybody take every pill every day. Although again, these are data that are modeled in men. If you're trying to look though at what's most efficient and the number needed to treat, what you can see is that, at high adherence, the number needed to treat is pretty stable. It's 20 to 25 person years to avert each infection. And you cross over multiple numbers if you've got low adherence, but you're still in the 40 to 60 range. So even with low adherence, you still have a fairly low number needed to treat. And then just to pull this all together, antiretroviral treatment and PrEP. Can we do it with just antiretroviral treatment alone? And so this is a really interesting study published recently from the Danish epidemic. It's modeling study in the Danish epidemic. They have a small population of men who have sex with men, and that's where their epidemic is most concentrated. And so they said, gee, if anybody can stop HIV, we should be able to do it. And you can see the proportion that are taking up treatment now. It's increased substantially over time, so that people who are newly infected are very likely to be on antiretroviral treatment. And you can see that here, that those red bars they're on treatment with complete viral suppression. This is the proportion who are remaining undiagnosed is going down. This is the proportion this middle line, who are diagnosed but not on treatment, and then there are very small numbers who are on treatment and not virally suppressed. So, so that all looks good, and they think they're actually at a point where they may be at a tipping point to get the reproductive rate less than 1. And it's still over 1, but they're hoping to get it less than 1. But when they look at, okay, what do we expect on average for each person who is capable of transmission, which means you either don't know about your infection or you're not virally suppressed, the number of transmissions per person is going up because rates of condomless anal sex are going up without PrEP. And so what they conclude is that the effectiveness, that they have the effectiveness of treatment as prevention under optimal conditions, and unless you can reach that, it's going to be extremely challenging to actually prevent an infection. So what I did was I created this table to look at how do we compare to Denmark. We have about the same size of the MSM population. Ours is slightly larger. We were a year ahead of them in starting to treat everyone with antiretrovirals, but we've both been doing it for many years. We have a much higher prevalence, 24% versus 5% in Denmark. We have a better rate, though, of people who are aware of their infection. They're being diagnosed around the same period of time. But we think that we don't have the proportion who are in care who are virally suppressed of 98%, and that's going to be quite difficult to achieve, and our estimated incidence is probably twice theirs. So, and we've got many more potential transmitters because we've got most people know they're infected, but we've got a lot of people who are infected but not fully virally suppressed. So I think there's no way we can end this epidemic in San Francisco without PrEP and without other prevention strategies. So I'm going to stop there because I'm out of time, and we'll talk about new agents and new formulations at another time. And thank you.
You ready to take a question?
Yeah.
Do we have any questions in the last couple of minutes?
Is the reason that women have to take oral PrEP daily in order to achieve protection, is that also due to the vaginal microbiome, even if it's an oral formulation?
Yeah, we don't know if it's about the vaginal microbiome. There are two things that are, we don't really know this issue about the vaginal microbiome yet. And that was a study that was done just with topical PrEP, not with oral PrEP. What we know is that tenofovir concentrates at 100-fold lower concentration in vaginal tissue than in rectal tissue. We also know that there are these, the degree of ATP and CTP in the tissue will compete with tenofovir for attachment. And so if you've got very high levels of ATP, it decreases the effectiveness of tenofovir. But I think that we're still in a data-free zone in terms of the vaginal microbiome, and what you can see is it's just the tenofovir level alone being so low is a big part of the problem.
I'm kind of curious about multi-drug resistant strain HIV, and as Truvada is being provided for PrEP, it's also one of the main drugs used to treat people living with HIV. So we're essentially selecting for Truvada resistance, and I'm curious if you're...
Yeah, so it's something that we definitely need to be tracking over time. There is tenofovir resistance in the community. We're not seeing breakthrough infections for the most part, but we've seen one reported, and I think that I've heard of a couple of others. I don't know what the details of those are. It still seems pretty rare. The good news is that we are getting some new agents being developed, and for instance, Merck is developing a new agent. I don't know the details of it, but they're planning to roll it out for prevention first rather than for treatment, and they're planning to use it to provide it as an implant Because one of the problems with the long-acting antiretrovirals, which is what I was going to show you next, but I think Vivek may have covered it last week, is just that the tail is so long, where you have a subtherapeutic or subprotective level, but it's high enough to develop resistance, that's really of concern. And so in our studies of long-acting antiretroviral prevention, we've got to cover the tail with oral TDF-FTC. This would be a situation in which presumably you wouldn't have to, because you're using an implant that once it's done, and you just keep replacing the implant. But if you don't want it anymore, then you can do that.
Susan, thank you so very much.
Thanks.